This is week 11, psychotherapy with groups, families, and couples. Some reminders and announcements. Unfortunately, week 10 has no content due to these continuing issues with the Laulima modules. So the course content won't be posted in the modules format anymore. It seems to be the main source of the issues. For some reason, anything I upload to Laulima, if I'm using the modules format, doesn't save. And so please refer to the announcement through Laulima for instructions to access content for this week. And of course, contact me if you have any questions or problems. Okay, so first we're going to talk about group therapy. And in the past, group therapy was kind of used when individual therapy wasn't economically possible, and it was used as more of a supplementary technique. So it started to emerge more in the 1900s, early 1900s, and then gained a bit more traction in at the end of World War II, where a lot of veterans were coming back to the US, and groups were used to handle the increase in need for therapy and counseling. More recently, it's respected and used as a standalone version of therapy, although very often it's still used in conjunction with individual therapy. And different therapeutic modalities have different approaches to groups. In psychoanalytic group therapy, a lot of the same components are used as in individual therapy, but the group members are kind of objects that the individuals in the group can kind of use to gain insight or increase their own insight into their issues and especially unconscious desires and beliefs. So free association is used where group members may freely talk about their kind of like feelings or impressions of other members. Dream analysis is used. Transference is examined, so transference toward the therapist and toward the other group members. Any resistance that an individual is showing may be interpreted both by the group members or the therapist. And as I mentioned, the group is kind of generally used as a vehicle to help individuals increase their own insight. And in many versions of psychoanalytic, or kind of in a pure version of psychoanalytic group therapy, there is less input from the therapist, so the therapist is less directive. But there are versions of psychoanalytic group therapy where the therapist is a little bit more involved and a little more directive. And then two versions of psychoanalytic group therapy are two like specific approaches within the broader modality are psychodrama and transactional analysis. For our purposes, I'm not really going to get into that. To the best of my knowledge, these aren't practices that are commonly used today. So I think I'll focus a little more on things that you actually would see a lot in general healthcare settings today. Gestalt therapy also has kind of a group corollary. So in Gestalt groups, you might focus more on the individual being aware of the immediate now. One individual is focused on at a time, and so they're kind of like in the hot seat, where other members may observe, or the individual or provide impressions of the individual that's in the hot seat. It incorporates role-playing and some dream analysis or discussion, and certainly dialogue between the patients or the clients. And Gestalt groups are sometimes take place in intensive environments or encounters, including like residential seminars, retreats, workshops of several days. And then there are groups that fall within the behavioral and cognitive behavioral modalities. And these groups, similar to CBT and behavioral approaches in individual therapy, these groups prioritize learning techniques and coping skills over focusing on the group dynamics. So for example, people may learn relaxation training as a group, skill building. You could, if you had a lot of people with similar anxieties, such as like social anxiety, you could build anxiety hierarchies together or engage in exposure therapy for social anxiety. There's also assertiveness training or general social skills training groups that are relatively popular. And then increasingly popular are DBT skills groups. So skills groups that use the four modules rather, of dialectical behavioral therapy. In behavioral and cognitive behavioral groups, the therapist often plays a more instructor role, kind of facilitating learning and providing information. These are usually time limited, just like individual therapy in this modality. So 8 to 12 sessions would be typical. They can go a little bit longer if it's more intensive, such as a DBT skills group. Typically meet on a weekly basis, and usually comprised of clients with similar problems. Since it is more skills-based, you would want clients that could benefit from the same skills. And it often includes homework, just like individual therapy in these modalities, and assessments at like baseline and maybe midway and afterwards to monitor the progress of individuals within these groups. So we've discussed some differences in the different modalities of group therapy, but there are many common factors as well. A group would typically have 5 to 10 members. The book had mentioned that 90 minutes to 2 hours is typical. It's been my experience that less than this is also typical. So a 50-minute session or an hour session is often typical just because it's more feasible for people, and certain populations have difficulty maintaining attention for over an hour, and also it can be hard to deal with really heavy emotional issues for long periods of time. So depending on who's in the group and the function of the group, it can be less than 90 minutes. The groups will usually meet once or more per week, with some groups, like in an intensive outpatient program, some groups will meet every day or every weekday. Members are usually seated in a circle facing each other, so this is one area in which psychology is accurately depicted in media. So if you've ever seen a movie or a TV show where somebody is in group therapy and they're sitting around in a circle, kind of like sharing their experiences with people, this is actually pretty accurate. This is what group therapy does often look like. The book mentioned that many therapists will exclude certain patients from a group. And my experience deviates from the book here. So the book had mentioned that people with severe cognitive limitations, people who are rather psychotic or very prone to disrupting group, will be excluded from group. And I think this is the case in many situations. However, there are groups that are specifically formatted for these people. So there are groups that are formatted for people with lower cognitive abilities, groups for people who are experiencing psychosis, and indeed the group process can be helpful for people kind of to what we call reality test, meaning if they're have the level of insight that they recognize that some of their thoughts and perceptions may not map onto everyone else's reality, they can kind of check with other group members, say, I feel like my wife's cheating on me and I don't have any data, and the other group members, or I don't have any evidence for it, and the other group members might be able to kind of help them walk through the process of figuring out whether that's paranoia or something that may actually be real. As well, for people who are very prone to disrupt groups, so DBT groups, dialectical behavioral therapy groups, are created for people with severe emotional distress and for people who do have a lot of difficulty managing interpersonal situations and relationships effectively. And so DBT groups do accommodate people who are prone to disrupting group. Of course, that comes with a limit. If somebody is completely flying off the handle every time they're in group, maybe they wouldn't be included, but people who are disruptive can be sort of like behaviorally managed in group, and it can even be part of the group process. So kind of getting feedback from other members of the group that they're disrupting group can be helpful for the members who are disruptive. Most groups have rules that you will say either at the beginning of every single group or at least at the beginning of like the series of group. So like in the first or second group meetings, for example. Common rules include confidentiality, so anything that's is said in the group stays in the group. And there's kind of an interesting dynamic where As a therapist, if I'm running a group, I am legally bound to keep that information confidential. I could be sued if I lose my ability to practice if I were to share client information outside of that, outside of like the therapeutic setting. However, other group members are not legally bound in the same way. So there is kind of a trust system that people are not going to go outside of the group and share things that other group members have said. Other common rules, in many groups, it's not allowed to show up actively intoxicated. It's common to encourage group members not to engage in, or not to form sexual relationships or romantic relationships outside of group, just because those kind of pairings within group can create the usual drama that comes along with relationships. Groups can be mixed gender or separated, and this can depend on what the function of the group is. So if there's a group that, for example, there's a military sexual trauma group at the VA within the consortium that where I work, and it's actually only men in that group. And the reasoning behind that is that all of these men have been sexually assaulted by other men, and so there's kind of a shared experience within that group of having a very specific type of trauma, and within a military setting as well. And so they've kind of chosen to keep it for just men for that group. And you could see something similar if there was a female sexual assault group, or a group of females who have been traumatized in the past. There can be justification for, most often there are male perpetrators of sexual assault for females, and so you could see there could be some reasons for not including males in that group. The group can be homogeneous or heterogeneous based on client characteristics. So you might include only people with social anxiety, or you might include some people with social anxiety and some people without social anxiety to kind of create models for the people with social anxiety. One or more therapists can run a group. It's actually really nice if you can have two therapists, because one person can be more the person running the group, and the other person can kind of handle small crises or deal with anyone who's not, who maybe is being disruptive to the group process. And then groups can be open or closed, meaning if a group is open, people can enter group at any point during the 12 weeks or however long the group is running. If it's closed, you have to enroll in the first week or two of group, and people cannot enter until the next kind of several week session has started. So does group therapy work? There's some indication of curative factors. It seems that imparting information is helpful. People receive guidance and advice from other group members, and as well a little bit from the therapist. There's a sense of hope that can be gained from seeing other people who have been more successful. So if you have people, for example, in a substance abuse group, if you have people who are farther along in the recovery process from addiction or from substance abuse, this can help members who are earlier in the process feel like there's hope and things can get better. There's also a lot of power in recognizing that other people have similar difficulties. So we see this a lot more recently with people with borderline personality disorder, which is a diagnosis that people are becoming more and more aware of. And I hear over and over again from people with borderline personality disorder how helpful it is to hear that other people are also struggling with these difficulties, with the same difficulties as them. Because it can feel very isolating to feel like you're the only one who has these problems. There's a sense of altruism that can be gained from groups. So if one of these clients who is further along in the recovery process is able to help clients who are earlier in the recovery process, this can increase their self-value and feeling more competent, and also just feeling good about themselves for being able to help someone. There's a lot of interpersonal learning, so learning to interact with other people in an appropriate way. The therapist and also other group members are kind of there to moderate behavior if somebody is being disruptive or disrespectful. There's also, I think I briefly mentioned this before, that group members can model behavior for other group members, or the therapist as well can help to kind of like model appropriate behaviors or adaptive behaviors for a variety of presenting problems. This is a more like psychoanalytic view, but there can be kind of corrections of any family processes that may be disrupting the group member's life. So the idea is that if somebody grew up with like certain family issues and learned maladaptive coping methods based on kind of family disruptions, the group can be sort of a proxy family where the person can learn how to deal with problems and understand problems in a more like sort of functional family type setting. There's a certain catharsis as well to being able to say your problems out loud to other people who are hopefully going to treat them in a non-judgmental way with someone you trust and someone you think might be able to understand you. And there's also, it can be helpful to just be around a lot of people who accept you and aren't judging you. So it's kind of similar, that there's often in a good group, there's a certain cohesion and sense of support from your group members. So again, does group therapy work? It is more efficient and economical than treating those 8 individuals in your group individually. It doesn't seem to be more, it is more effective than no treatment at all, which is good. But it doesn't seem to be necessarily superior to other treatments. So there isn't good evidence that group therapy is superior to individual therapy, although I think that might vary based on the individual and the presenting problems of the individual. So we, as is often the case, we really just need more research to better understand situations where group therapy might be indicated versus individual therapy, or where a combination of group therapy and individual therapy might be ideal. It is currently underutilized and kind of viewed as the second choice form of treatment. So viewed as like, okay, if we don't have an opening for individual therapy, they go in the group until we have time to like deal with their problems one-on-one, which, as I mentioned before, may not be ideal. It might be the case that group therapy is a better treatment for certain people. So looking ahead, it does seem that demand may be increasing for group therapy, and this is partially due to the influence of managed care. So healthcare systems are more likely to reimburse group therapy because it takes, and also to support the use of group therapy because it takes less time, it takes less staff per client, and it is less expensive. Alternatives to inpatient treatment already rely heavily on groups. So I mentioned before, I think outpatient, intensive outpatient care, which is sort of like that every day, every weekday you show up and do several hours of therapy. Partial hospitalization programs are kind of a very intense version of intensive outpatient care, where an individual isn't an inpatient, so they're not like in a locked inpatient unit, but they are going every day to the hospital or to a specialized clinical setting, and a lot of what they're doing during that day is just groups. Lots of group therapy, and they probably have an individual therapist and medication management as well in these programs. So moving on to family therapy, this is generally different from involving family members in individual therapy, which is another helpful thing that can happen in individual therapy. So sometimes if you're working with an individual client, there may be specific issues with another family member that can be worked on by bringing the family member in, but that family member is not a client. They're not in therapy. So family therapy is referring to all members of the family or certain members of the family together undergoing a single therapeutic intervention, or a joined therapeutic intervention rather. Typically, a therapist would conduct an assessment of the family history and present that information to the family to start therapy and justify the intervention and the goals. The therapist learns about the different roles in the family and the specific subcultures of that family. The role of the individual is typically de-emphasized within family therapy, although an individual within the family can be getting therapy outside of the setting. And the family is focused on as kind of a whole functioning unit. Communication is of vital importance, as it is anytime you're dealing with more than one person, or even with one person. So there's a general idea that pathology in the family unit or issues within the family unit are often related to poor communication amongst the members. The general systems theory is that the family is a system and pathology is reduced by altering the way that that system functions, which makes a lot of sense. And there's a focus on an unbalanced state within a family and achieving kind of a homeostasis or a balance amongst the family members. A family therapist will avoid identifying with one family member more than others. So I think it can be kind of natural for someone engaging in family therapy to sort of feel like one person's right and one person's wrong, or that somebody kind of has more validity in what they're saying, but it's very important for a therapist to maintain neutrality in these terms. There's some origins in schizophrenia treatment work in family therapy. So there were some early theories that family systems can cause schizophrenia. And when I was reading that section in the book, I didn't think that the authors were entirely clear that it's just part of the history of family therapy, and these are no longer considered to be valid hypotheses about schizophrenia. So I think there used to be something called like the schizophrenic mother, kind of blaming mothers for their children developing schizophrenia, and some of the other theories that were mentioned in your book also kind of like blamed the family for people developing schizophrenia. And while family stress and distress and high negative expressed emotion can certainly be a risk factor in people developing schizophrenia, I think it's really important to just be super clear that your book was not saying that families are responsible when an individual develops schizophrenia. So there are a number of different types of family therapy. One is conjoint family therapy, where the entire family is seen at the same time as a therapist, by a single therapist rather. And this therapist observes the family dynamics and then models and acts as kind of a teacher, encouraging improved communication between family members. And within this type of therapy system, there's kind of 5 forms of communication. Placating, which is agreeing no matter what one actually thinks. So you could see somebody who's a little more submissive within the family unit would be placating a lot as a form of communication. Blaming is criticizing other people and failing to take responsibility for your own actions or your own emotions in a family system. Being super reasonable is a negative communication style, where an individual has reasoned answers to everything, but they're kind of not including feeling and emotions in those answers. Irrelevant communication is responding in unrelated ways, so sidetracking the conversation or sidetracking the communication. And then congruent communication is communicating what an individual genuinely feels, and this is obviously desired. In concurrent family therapy, there's the same goals as conjoint family therapy, so you want the family to work together as a unit, and there still is one therapist, but the therapist meets individually with the different family members. And this can be useful. It kind of just depends on the family presentation, which is most useful. And then in collaborative family therapy, there are multiple therapists seeing different individual family members, but the therapists collaborate and discuss the family as a whole with one another to plan the treatment for those individuals with the goal of both helping the individuals in their individual problems and helping the family work better as a unit. Behavioral approaches to family therapy focus on reinforcement contingencies and skills training within the family, so very behavioral approach, of course. There may be a full behavioral analysis of family problems, including looking at antecedents or things that come before issues in families. So if there's like a big fight on Thanksgiving or something like that, looking at what happened before that fight occurred or when the fight was kind of ramping up, looking at the behaviors of the individuals within the incident, so within maybe a family argument, and then the consequences, what happened afterward, how were things resolved, were there apologies, or did everyone just kind of like storm off and ignore each other? In behavioral approaches, you want to identify which behavior should be increased or decreased, and using, of course, behavioral theory, looking at how rewards and consequences might be implemented or modified to optimally increase or decrease behaviors. The therapist aims to help family members provide the correct reinforcement for one another, and this is, of course, very similar to a lot of CBT approaches of modifying behavior and emotions. Multisystemic therapy is a relatively new type of intervention that you hear about a lot with young people who have more severe behavioral problems. It was initially designed for juvenile offenders and their families, and as a way to acknowledge that maybe a lot of clinical problems are caused by multiple factors in a young person's life, with family within this model at least being the most important factor. So the idea when it was developed with juvenile offenders is that young people who break the law and get in a lot of trouble are influenced by, or interventions can occur within the family system, within the school system, and within like the broader neighborhood system. It's currently used with young people with other behavioral problems, not just juvenile offenders, so just more low-level rule breaking, substance abuse, and then within a family where there's substance abuse and or neglect, and sort of dealing with the outcome of that, and with trying to change behaviors and behavioral patterns and kind of emotional discord within those families. In multisystemic therapy, the youth is highly monitored, so there's a lot of, it's a very intensive technique. Outcomes are recorded and tracked and logged to see if the intervention is working or if it needs to be modified. There's definitely a heavy focus on evidence-based behavioral interventions, so rewards and consequences again. And it's, as I said, a very intensive treatment. Therapists are available 24 hours a day, 7 days a week, which is a lot for the therapist. And so caseloads have to stay pretty low, and the therapist should ideally serve on a team where they have kind of backup and support. Unfortunately, there aren't many well-controlled studies for family therapy, and so it's hard to really have a coherent idea of the research base and evidence-based techniques in family therapy, but there do seem to be some active ingredients, one of which is the ability to define the problem as a family problem, so as opposed to a problem with an individual or two individuals within the family, kind of broadening it to something that the family is going to deal with together. Therapeutic alliance between the family and the therapist is important. If there's a reduction in negative interactions in the session, this is predictive of better family functioning after therapy, and improved communication is considered to be an active ingredient of family therapy. There are some versions of family therapy that may be superior to some individual therapies in certain situations within certain disorders, but, and your book mentioned one or two of these, but I think it's really important to note that this is rather preliminary research, and there may very well be a selection bias where families who are willing to come in and participate in group therapies are generally more supportive, so individuals within those families may already be kind of set up to do better than those whose families would not be willing to participate in group therapy. Okay, and finally we have couples therapy, and important to note that this can be for married or unmarried couples, and of course this includes same-sex couples. Hopefully this would also include like polyamory or any sort of setup or intimate relationship setup that people have chosen. It can be seen as a form of family therapy, and indeed it shares a lot of the same principles as family therapy. There are a number of couples therapies that are out there and that are used, including behavioral marital therapy, emotional couples therapy, emotionally focused couples therapy, sex therapy, insight-oriented therapy, or couples therapy, which is psychodynamic modality, and then there are others as well. Behavioral marital therapy does not specifically refer only to marital couples. The word marital was kind of an artifact of the period in time in which this therapy was developed, but of course it applies to all different types of couples. And in this therapy, reinforcement principles are applied to couples interactions. So one way this is done is with contingency contracting, where one partner agrees to modify their behavior in order to affect a specific desired behavior in the other individual. This can, of course, go both ways. Both partners can engage in contingency contracting. And then there's support understanding techniques. So this is kind of a way of supporting your partner and sort of increasing positive interactions and positive responses in the other individual. For example, each partner might agree to, or a list is generated of different things that one partner kind of like wishes the other one would do. And then both partners agree to pick maybe like 3 things from that list that they're going to do before the next session. And then problem-solving techniques are employed. So both partners are, both or all partners are trained in positive communication skills that can allow for better decision-making and better negotiating and just generally better communication within the partners. In emotionally focused therapy, the goal is to change negative emotional interaction styles in order to create a more secure emotional bond. So treatment can include, I think there are 9 steps typically in EFT, or EFT couples therapy, but generally the idea is that the therapist will assess the problematic interaction cycle and the emotions that are connected with these problematic cycles, so kind of bad habits and cycles that couples get caught in. And then the therapist and the couple together create better, more adaptive ways to interact that meet both the needs of the self and the partner on both sides. And then the third step is like bringing this into real life and integrating these solutions into everyday life. Unfortunately, there haven't been a ton of studies on couples therapy and the effectiveness of couples therapy. There is some indication that some approaches may be more effective than others. Both BMT and EFT have been proven efficacious, so like in a more controlled setting, they've been shown to work. There's also indication that EFT may be a better fit for higher distress cases as compared to BMT. And couples therapy in general may be effective in treating individual issues. So if one member of the couple is experiencing anxiety or substance use or depression, things that we would target typically with individual therapy, it does seem to be the case that those symptoms and those behaviors may also be addressed within the couple pair and made better through couple therapy.